Hi, my name is Karen Clancy, and myself, Samson, and Melissa are presenting EMDR. EMDR is a form of psychotherapy, and it's designed to reduce trauma-related depression, stress, and anxiety. It's actually designed to improve overall mental functioning. It's a three-pronged protocol that disrupts stored memory of trauma, and it deals with both the past, present, and the future. EMDR uses bilateral stimulation by using tones, taps, or eye movements, and it actually moves the memory of the trauma to a different part of the brain for storage. Helps to get rid of beliefs, emotions, and symptoms regarding trauma, and it connects with adaptive information stored in the memory. It has elements of cognitive behavioral therapy, body-centered therapy, experiential therapy, and interpersonal therapy. And it is effective, it has been found effective with several different groups. This is a list of some of the groups that EMDR has been found to be effective with. So it's effective with sexual assault victims, victims of man-made or natural disasters, crime victims, including police officers, firefighters, any emergency volunteers or EMTs that have dealt with trauma, that are experiencing symptoms that nightmares and flashbacks, typical PTSD symptoms, combat veterans, persons with anxiety disorders or panic attacks, phobias, and accident and burn victims, as well as many other individuals that it has been found to be effective with.
Hi, my name is Melissa, and I am going to describe the 8 phases of treatment for EMDR. Phase 1 is a basic history-taking session in which the clinician takes a psychosocial diagnostic interview to determine the client's issues, whether or not they have self-soothing skills, and whether or not they are ready for reprocessing, and also at that point the clinician and client develop a treatment goal. Phase 2 is in a separate session, and it is preparation. And the preparation phase prepares the client for EMDR by providing information, setting expectations for the course of treatment, identifying client coping skills, and strengthening the client-clinician relationship. Phase 3 is assessment, and it is the process in which the clinician stimulates the client's memory and assesses the client's baseline reactions to the targeted trauma. In this phase, the clinician is looking for somatic responses to the trauma as the client talks a little bit about whatever the session is focusing on. Phase 4 is desensitization. That phase involves trauma-focused bilateral stimulation, and this bilateral stimulation in the form of eye movement, or sometimes they will have headphones on with bilateral stimulation where the music goes back and forth between the right and left side, or sometimes it just involves tapping where the client is instructed to bilaterally tap their leg, right hand and then left hand, and back and forth. This will help to reprocess the trauma memory. Basically, it fires both sides of the brain while the client is focusing on the trauma and helps the trauma to be restored in a different part of their memory. Phase 5 is installation, and it strengthens and enhances associations to positive memory networks. This phase involves connection to positive memories stored in the client's brain, and then the clinician helps to attach the positive memory to the negative memory, and thereby basically desensitizing the negative memories. Phase 6 is the body scan. And this stage reprocesses any residual physical manifestations of the memory, accesses the belief, of the client around the memory, scans the body, and reprocesses sensations. So during the body scan phase, the clinician is basically just staying in touch with the client and asking, where do you feel the sensations in your body? Where are you feeling the pain, or where are you feeling whatever's going on? Phase 7 is closure, and closure reorients the focus of attention to bring closure to the reprocessing. It involves client stabilization, session closure, and client reorientation to the present. So basically in this phase, it's really essential to bring the client back to the present moment. Otherwise, they will stay stuck in the past memory. A plan is developed for the time between sessions, and another appointment is made. And so the client agrees to do whatever the clinician and client agree that the client will do to help further the client in this process. So phase 8 is reevaluation. And this phase is often conducted at the beginning of a subsequent treatment session to evaluate the impact of previous sessions. It's utilized to evaluate specific target memories, identify other relevant associations that may have been triggered by the reprocessing, and evaluating client progress. Again, reevaluation is typically done at the beginning of each session, and so this will make the patient and client, the client and the clinician aware of the client's new baseline, and give the clinician a starting point for the upcoming session. Again, EMDR does incorporate elements of other clinical approaches that are compatible with the adaptive information processing framework. However, it is distinct in that it addresses the physiological effects of stored memories. So other courses of EMDR treatment can include customized procedures and protocols within the adaptive information processing framework, such as self-soothing techniques, skill building, and enhancing access to positive networks.
Review of literature. Although EMDR has been recognized as an evidence-based practice, more studies are needed to find out what clients it works best with in comparison to other exposure therapies in CBT. In a few of the articles I read, EMDR was regarded as one of the better exposure therapies because it proves to be just as effective with more rapid treatment gains, which is beneficial for patients prone to drop out early in treatments when alleviation is not immediately apparent. It does not require patients to disclose specific information about their disturbing experiences. It does not require homework. They also have lower dropout rates for military populations in comparison to prolonged exposure and CBT. It uses a neuroscientific model, and it's client-centered, which contributes to the formation of a good working therapeutic alliance. However, like all therapies, it all depends on the client and what works best for them. The literature also suggests that with these distinct advantages over other exposure therapies and its growing popularity with military clients, EMDR can be just as effective as CBT in certain situations. More than a handful of the articles I read all question the effects of the dual stimulation, in which many have regarded it as merely a disguised exposure treatment and referred to the bilateral stimulation as a placebo-like gimmick. Although the role of eye movement has been quite controversial, every study I found has proved that it plays a critical role in treatment. In fact, it was found that eye movement increased hemispheric interaction between the left and right hemisphere. In addition, participants' performance in a test of episodic memory improved when preceded by horizontal eye movements compared to vertical eye movements or an eye's stationary condition. Along with treating depression, anxiety, and stress, the effects of EMDR were associated with reductions in anger and guilt. Modifications to EMDR were made later on to better suit its use with children. However, unlike the high regards it received amongst adults, its results with children were inconclusive compared to those with adults. Although it did receive mixed reviews and is still considered a promising treatment for children suffering from PTSD, more studies are needed to confirm its validity and efficacy with children, as they are a vulnerable population. And finally, in a study examining the time course of changes in vividness and emotionality when reliving unpleasant memories, studies found that emotionality depends on vividness, in which the result of low quality, less rigid images becomes less impactful emotionally. After 2 seconds of eye movement, there was a significant drop in vividness of the unpleasant memory. Decrease in emotionality happens more gradually than changes in vividness. And here are our references.
Hi, my name is Melissa, and this is my client Karen. And we are going to do a partial session of EMDR. During my research, I found out that we can't actually do the core process of an EMDR session on tape because there are copyright laws, and I am not trying to get in any kind of trouble with this. So what Karen and I are going to show you is a combination of phase 1 and phase 2. And so what I will be doing as the therapist is taking a history and basically assessing client readiness for EMDR and preparing the client for what's to come by giving an overview of what this therapy is going to be like. Hi Karen, how are you?
I'm good. How are you?
Nice to meet you. Thank you for coming. So
Yeah.
let's talk a little bit about why did you choose EMDR?
Well, I have kind of heard a little bit about it. When I was going to counseling, because I actually, I went through some counseling, and, I learned a few mindfulness skills, just some basic coping things, which helped, but I'm still having flashbacks and nightmares. I really, for whatever reason, I can't get beyond that. And I've heard, my therapist actually told me about EMDR, gave me a little bit of information. I'm not really sure I have a lot of information, but, just kind of threw it out there as something that I might want to try.
Okay. And so you have a diagnosis of PTSD?
Yes, I do.
And how long ago was the traumatic event?
It was about 7 years ago.
Okay.
It was about 7 years ago.
What other forms of therapy have you tried since then to deal with this?
Just really, what I would say is talk therapy.
Okay.
Going in and talking to a counselor. And like I said, she taught me a couple of mindfulness, kind of breathing exercises to calm myself down. But, I don't know, I still keep the flashbacks and the nightmares are something that I can't get beyond. Okay. So I wanted to try something different. I'm better from the talk therapy, I would say a little bit, but I still am not at a point where I really want to be.
Okay. Tell me how you're better. What's different now than when you first started therapy?
Well, when I first started therapy, I was really, really depressed. I couldn't get out of bed. I didn't want to see my grandkids. I just really kind of cut people off. Okay. I was so fearful I wouldn't even leave my house. The rape really changed me, and it really made me fearful of people. So I have, I've improved, okay, but I still have some symptoms. I just feel like I really want to get better.
Okay. So tell me what happens when you have a flashback of that event.
I have panic attacks. Okay. I start breathing really, really fast. I sweat. It's almost like I'm frozen. I feel like I can't do anything. Okay. And the nightmares, when that happens, I wake up and I can't get back to bed. I just, the fear, that someone's outside my door, someone's going to break into my house, I'm going to go through that again. I just kind of get frozen and stuck.
Okay. At what times during the day are you having the flashbacks? Is it different every time, or is it the same time? Is it every day, or?
I would say it's probably, I daily have flashbacks, And usually sometimes it's a loud noise that will, really, bring that on. Or, he held a knife to my throat, and so if I see a knife, sometimes that'll trigger a flashback. So those are a couple of things. If I, just loud noises is the big one. Or sometimes when I'm, at home at night, I'll have a flashback if I'm by myself and, just afraid to go to bed.
Okay. And so it sounds like the flashbacks are externally triggered. So something external, you see a knife or something reminds you of it, and it triggers a reaction.
Yes.
Do the flashbacks ever happen when you're driving, or when, let's say, you're at work or with family, or when you're alone?
It's mostly when I'm alone.
Okay.
I think once in a while it'll happen if I'm out in public and I just hear a really, really loud noise. Because he broke into my home and punched the door down and really pretty much broke my door in, and so loud noises is a huge one for me. Okay. So if I'm at the mall and I hear a really loud noise, sometimes that'll bring it on.
So it just takes you right from where you are back.
Mm-hmm.
Okay.
Yep.
Okay. Okay, so what I'm going to do is just explain to you a little bit about the process to just kind of prepare you a little bit. Understand that treatment for each person is very individualized, and it's different for every person.
Okay.
Some people move through the stuff quicker than others, and that's okay. So whatever your process is and whatever pace you take to move through this is okay.
Okay.
There are no expectations. I don't have expectations, and so I don't want you to have expectations of, okay, after treatment 6, I'm going to be healed. So it's just different for each person. Okay. And so tell me what you know about EMDR right now.
Well, I don't know a lot. I know that it's supposed to, I don't know what exactly you do, but I do know that it is taking the memory of the trauma and storing it in another part of the brain.
Okay.
And I have done a little bit of research, and I, have what the research that I've done says that it's effective, and that more research is needed, but that the research that has been done seems very promising. That people's stress levels come down and just different things like that. So that's about all I know at this point.
Well, it is an extremely promising intervention for people with PTSD, and basically it is a psychosocial therapy, and you and I will just be talking in a regular therapy session, and I use one of 2 bilateral stimulation techniques, and so sometimes I'll have you put on headphones, and there will be music that will be bilaterally moving back and forth from the right side to the left side.
Okay.
What that does is, while you're telling me about what happened and about what is going on, then it trains your brain to fire on both sides, and that trauma that's in your face all the time right now, and you can't even see around it, it trains your brain to restore that trauma in a safer part of the brain, so it's not in your face all the time.
Really? While you're listening to music?
Absolutely.
Wow.
And then sometimes it's just bilateral stimulation, like following the head of a pin while we're talking.
Okay.
And so
wow.
So, and then sometimes people use the bilateral tapping. And so there are several phases of treatment. And so right now we're in the initial stage, and we're just kind of getting to know each other a little bit, and finding out if there are expectations, if you have expectations of treatment or progress or whatever, and you and I will decide on a course of treatment for you.
Okay.
And so each time that we meet, we will reestablish your baseline. And so hopefully your baseline functioning will go up every time, and you'll have a new baseline.
Okay.
Okay?
Okay.